Now for the cardiac portion of cardiovascular physiology, having discussed venous return and the venous return curve in part 1, which was given to us by Dr. Guyton, we're now going to focus on the Frank-Starling cardiac function curve and a little bit more detailed analysis in terms of the Sagawa pressure-volume relationship. And the difference between these curves and the relationships between these two curves I think will become more clear as we fly through part 2 of chapter 2. So we've only considered the circuit function, that was the venous return curve that we discussed. In the last part, that is the difference between, or the relationship between right atrial pressure and venous return from the venous capacitance beds. But the, quote, cardiac response curve, or the cardiac function curve, or the Frank-Starling curve, you can call it whatever you want. I just chose cardiac response curve because that's what Dr. Guyton called it, relates right atrial pressure to cardiac output. And it's really has an inverse relationship to compared to the venous return curve, as we will see. So while circuit function, the circuit function curve is shifted in response to a number of variables, like, as we discussed previously, total volume, and the fraction of total volume into stressed and unstressed volume, excuse me, the compliance of the venous beds, and the resistance to venous return. The circuit function, or the cardiac response curve, or the cardiac function curve, also will shift left and right in response to a number of variables. And there seems to be this notion out there that the cardiac response curve, or the cardiac function curve, or the Frank-Starling curve, shifts left and right just in response to cardiac contractility. Like, you sort of picture yourself giving the patient some adrenergic drugs, and then the cardiac function curve shifts up and to the left, and you beta block them, and then the cardiac function shifts down and to the right, and that's it. But actually the cardiac response curve, as we'll see, it just tells you the relationship between right atrial pressure and cardiac output. And as you know, cardiac output, which will be on the y-axis, is determined by heart rate and stroke volume. So this curve will shift in response to shifts in heart rate, up and to the left, down and to the right. In addition, anything that changes the stroke volume, and we'll get into what are the determinants of stroke volume as well. So this is this cardiac function curve, or the cardiac response curve, that I just introduced to you. And you can see it just says for a given right atrial pressure, which is a surrogate for stretch, or a surrogate of volume, which is your preload, for a given right atrial pressure you get a given blood flow, or cardiac output, and that's in liters per minute. This is like bulk flow. But it's a stupid curve. It just tells you for a given stretch what your output is. So you can imagine that changes in valve function, changes in afterload, changes in contractility will all cause changes in the amount that the heart can put out in response to what the heart gets in. You can sort of think of this curve very simply as just that, as the right atrial pressure is a surrogate of what the heart takes in, and this curve just describes what the heart pumps out. So like the circuit function curve, the cardiac function curve illustrates an augmented cardiac output with a higher right atrial pressure. So it's essentially just the inverse of the circuit function curve. Excuse me. What do I mean by that? Well, remember the venous return curve goes like this, the cardiac function curve goes like this, so they're essentially inverses of each other. That is, if you increase right atrial pressure, you get more output for the cardiac response curve. Whereas for the venous return curve, if you lower right atrial pressure, you get more venous return. So comparing this cardiac response curve, this right atrial pressure here, to this right atrial pressure here, well, what do you have? There's an increase in cardiac output, but comparing those two right atrial pressures. And the mechanism behind this is just increased myocyte stretch, and as you stretch myocytes, the troponins become more sensitive to calcium. It's the stress-induced calcium sensitivity, and you get a greater contractile force. It's the Frank-Starling mechanism, which has been known since the mid-1800s. So this curve here depicts a left upward shift. This is an increase in cardiac function, which is similar to an increase in circuit function, which we described in the first portion of this chapter. So if you compare the same right atrial pressures with this cardiac function curve, you can see that there's not only a greater cardiac output for each right atrial pressure, but there actually tends to be more of an increase in the absolute increase in cardiac output between these two right atrial pressures. Whereas a shift down into the right of the cardiac function curve does just the opposite. You have a lower cardiac output and less of a response between the same two right atrial pressures. Now, we'll talk a little bit more about this in later slides, I think more actually in part 3 of this chapter. But this point is really critical. I can't stress this enough, and essentially this point here tethers, for the most part, tethers heart-lung interaction. And that is because if you could imagine the scenario where you clamp the SVC, you clamp the IVC, you stop the heart, and then you put in a catheter into the right atrium and you measure the pressure in the right atrium, well, the pressure in the right atrium will receive the intrathoracic pressure and will be equivalent to the right atrial pressure, or equivalent to the intrathoracic pressure. So this pressure here, that's what I'm saying, is if you stop blood flow, arrest the circulation, and then you uncouple venous return from the heart, then the pressure in the right atrium will become the right atrial, or will become the intrathoracic pressure. So this point here on the x-axis, the x-intercept here, is slightly subatmospheric, and that's because the intrathoracic pressure is slightly subatmospheric. And as you can appreciate, that as intrathoracic pressure changes with respiration, so too will this curve. Critical point. So, cardiac function curve relates right atrial pressure to cardiac output, as I've kind of discussed, is rather a gross method of analysis. So, it shifts not only to changes in contractility, but changes in diastolic properties, afterload, heart rate, valve function, and I hope to prove that to you using a little bit more of a detailed graphical analysis of cardiac function, which I'm sure some of you have seen, and this is the Sagawa pressure-volume relationship. And it lends itself a little bit better into understanding how changes in diastolic and systolic properties of the heart affect the global cardiac function curve. And it also allows for analysis of valvulopathies and afterload abnormalities, which I'll get into. So this is the Sagawa pressure-volume relationship, or the ventricular pressure-volume curve. And what we'll first talk about here is the end-diastolic pressure-volume relationship. And this describes the ventricular diastolic properties and gives a qualitative understanding of ventricular filling. So this is what describes, we'll talk about the left ventricle here. This is what describes the left ventricular volume pressure relationship during diastole. So you can see here that it kind of looks like a hockey stick. And what happens is, following preceding systole at your end systolic volume, the relaxed ventricle fills from the end systolic volume to the new end diastolic volume. And this gives you your end diastolic volume and end diastolic pressure. Systole then begins once the end diastolic volume is reached. There's an abrupt increase in intracavitary or intraventricular pressure without a change in volume. This is isovolumic contraction. And then once the diastolic pressure is reached in the aorta, the aortic valve then opens and ejection proceeds. And ejection follows this curve. And now you can see that volume is decreasing, pressure is increasing along this line here as blood is ejected from the ventricle into the aorta. And then you reach the end systolic pressure-volume relationship, and this curve here is a graphical representation of the ventricular pressure-volume relationship at maximal during systole. It essentially represents maximal systolic elastance during the cardiac cycle. And the slope of the end systolic pressure-volume relationship is related to the contractile state of the heart. And once this end systolic pressure-volume relationship is reached, then relaxation begins. You get isovolumic relaxation, and then you return to your end systolic volume, and you, at this point, then begin diastole again. And you can see that clearly the difference between the end diastolic volume and the end systolic volume is stroke volume. And remember that cardiac output is stroke volume multiplied by heart rate. So you can automatically start to appreciate that there's a relationship between this beat-to-beat graphical analysis of cardiac function, which determines your stroke volume, and the Frank-Starling curve, which is more of a bulk flow graphical analysis. So let's talk a little bit more about the end-diastolic pressure-volume relationship. As we just saw, it describes the diastolic properties of the ventricle, and here we're talking about the left ventricle. And it's a change in pressure in response to a change in volume, and this is known as elastance, which, as we talked about in Chapter 1, is the inverse of compliance. So it's sometimes referred to as the diastolic elastance curve. And you can see that in diastole is a very low elastance, or a high compliance. It's very distensible and stretchy, which means that you can have very large changes in volume with very small changes in pressure. So this curve here that I've cartooned represents pure diastolic dysfunction. So this is essentially an increase in elastance or a decrease in compliance. And graphically you can see that compared to this patient with normal diastolic properties for the same end-diastolic volume, remember volume is on the x-axis here, they have a much higher filling pressure. And this is the graphical representation of diastolic dysfunction. So there's many things that can cause this, as I'm sure you can appreciate. I think classically everyone thinks of this thick, stiff left ventricular hypertrophy that you get with a lifelong poorly controlled hypertension, which certainly can do it. And various restrictive cardiomyopathies that are always on board exams but you never actually see in life can cause this. But importantly, and I think this is frequently forgotten, volume loading of one ventricle, or really any cardiac chamber, causes an acute diastolic dysfunction in the opposite ventricle, and this is known as ventricular interdependence. And the relationship and the magnitude of ventricular interdependence between the right and left ventricle is actually quite complicated and actually quite interesting. And it depends on the relative compliances of the septum to the free walls of the right ventricle and left ventricle. But just bear in mind that if you volume load the right ventricle, you can actually cause, and this is very well documented in the literature, this acute diastolic dysfunction in the LV in the left ventricle. And it reminds me of a patient who I just recently had in the intensive care unit who had bad pulmonary hypertension, and he had a PE, and then actually went into PEA arrest, and he was resuscitated and brought into the intensive care unit, and we floated a Swan-Ganz catheter in him, and he actually recently had an outpatient right heart cath just a number of weeks before this event. And during the PE he had a wedge pressure of 24, and during his outpatient right heart cath he had a wedge pressure of only 12. And his body weight and his total volume status between his right heart cath just a month before and his right heart cath in the intensive care unit in the setting of an acute PE, his pulmonary capillary wedge pressure had doubled. And it had most likely occurred as a result of an abrupt increase in right ventricular afterload. And we could actually see this on his bedside echo, increase in his right ventricular volume, changes in the interventricular septum, and then changes in his end-diastolic pressure-volume relationship of his left ventricle. And so higher filling pressure to achieve the same stroke volume or lower stroke volume is essentially the definition of an impaired cardiac function curve, and would be represented by a down into the right shift of the Frank-Starling curve. So now let's talk a little bit about the end-systolic pressure-volume relationship. And this gives us qualitative understanding of the contractile state of the LV. So this is the end-systolic pressure-volume relationship here, and this is the end-diastolic, which we just looked at. It's sometimes referred to as the systolic elastance curve, for reasons I've already discussed. And you can see that in systole there's a very high elastance, which is a low compliance. So if you compare the slope of the end-systolic pressure-volume relationship to the slope of the end-diastolic pressure-volume relationship, you'll see that the elastance is quite different. And this means that a small change in volume will result in a large change in pressure. So going through the cardiac cycle in this pressure-volume relationship, you can see that in pure systolic dysfunction, which is a shift down and to the right of the end-systolic pressure-volume relationship, this would be like a true impairment in your contractile state, or a patient with a beta blocker overdose, a patient with dilated cardiomyopathy and an EF of 10%. What this does is it results in a higher filling pressure to achieve the same or lower stroke volume. And again, just like in diastolic dysfunction, you have a higher filling pressure with the same or lower cardiac output, barring any changes in heart rate, is the definition of impaired cardiac function. So the Sagala pressure-volume relationship, I've been talking the qualitative cartoons that I've just showed you are essentially the relationships for the left ventricle, and it's similar between the right and left ventricles, but there's certainly qualitative and definitely quantitative differences between the two. Qualitatively, the right ventricular isovolumic contraction, that initial change between end-diastolic volume, end-diastolic pressure, and aortic diastolic pressure, is much attenuated in the right ventricle compared to the left ventricle, and ejection in the right ventricle actually continues beyond the termination of left ventricular systole. And I'll show you the cartoon of what that looks like in the next slide, but this is probably the reason that the right ventricle takes on this curve is probably because the afterload of the RV is much lower than the systemic bed. The pulmonary vascular bed is very compliant, very recruitable, very distensible, has a lower resistance. And so that increased pulmonary arterial compliance, in addition to systolic ventricular interdependence, which means that a good portion of the pressure, right ventricular systolic pressure, is actually generated by contraction of the left ventricle, that actually continues flow forward beyond peak elastance of the right ventricle. And then quantitatively, I think we're all quite aware that the left ventricle generates much higher pressures, with normal systolic pressures well above 100, whereas the right ventricle, it's normal to be below 30. So this is a qualitative difference between the right ventricle in red here, which has a lower and kind of curved isovolumic contraction. And then you can see that in the left ventricle, once you hit peak systolic elastance, then you have an abrupt linear drop in pressure, and your volume in the ventricle doesn't decrease anymore. Whereas in the right ventricle, it kind of slurs out, and actually volume continues. You have continued ejection in the right ventricle, and volume in the right ventricle continues to decrease even beyond peak systolic elastance. And it's probably a combination of the very compliant bed into which the right ventricle ejects, in conjunction with systolic ventricular interdependence. That is, the ventricle continues to create forward flow, or create pressure, which facilitates right ventricular ejection beyond peak elastance. So this curve obviously demonstrates the qualitative but not quantitative differences, because the quantitative differences are fourfold between the two ventricles. In this, we've talked about elastance, the elastance between the end-diastolic pressure-volume relationship and the elastance of the end-systolic pressure-volume relationship, and how they're quite different. And as I think you could probably appreciate, it's not a black and white issue. It's not a quantal on or off state. It's, very low elastance followed by very high elastance. But it actually lays on a continuum between full relaxation and contraction during a cardiac cycle. And this continuum is known as time-varying elastance. And it's also important to note that the elastance of the ventricle is changing during a single ejection, but also the elastance of the aorta or pulmonary artery is also changing. So there's also an elastance of the vascular bed into which the ventricle is ejecting. And the superposition of the time-varying elastance of the ventricle and the artery yields a graphical representation of something that you may have read about in physiology papers, and it's this notion of time-varying elastance. So the elastance of the artery is a composite variable that best represents ventricular afterload. And I'd like to graphically represent this with this following cartoon. I'm probably going to get emails about this. Well, I'm probably not going to get any emails because I don't really know if anyone's watching these videos. But this is sort of a model of what's happening in time-varying elastance. It's not exactly correct because in terms of the arterial elastance curve, part of this is going to be because the way this depicts time-varying elastance of the artery, it makes it look like the volume of the aorta or the pulmonary artery is decreasing with time. And as you know, during ejection, the volume in the ventricle is decreasing, but the volume in the aorta or pulmonary artery is actually increasing. But this cartoon is more to kind of make you appreciate that there is this time-varying elastance of both the ventricle, be it right or left, and the artery, be it the pulmonary artery or aorta, during a given cardiac cycle, and that at the end of a cycle, this composite arterial elastance line, it's a curve, it's a linear line, is an approximation of, it's a summation approximation of afterload, and it helps represent this idea of ventriculovascular coupling. So the red will be arterial elastance, the blue is ventricular elastance. This is the cardiac cycle that we've talked about. So watch this. This is the change in ventricular elastance and arterial elastance during only one cardiac cycle. So that was a single beat. And if you want to see that again, you can see that as the ventricle ejects, that it follows this curve, and this is a pressure-volume curve, and the volume is decreasing in the ventricle. But what's determining the instantaneous pressure along this curve here is actually an intersection of the time-varying elastance of the ventricle and the artery into which the ventricle is ejecting. And then it comes to this point where the end-systolic pressure-volume relationship, or the end-systolic elastance curve, meets the arterial elastance curve. And you can appreciate that the end-systolic pressure-volume relationship can shift up and down as a response to inotropic state. And actually this elastance curve, your arterial elastance curve, this line in red, can actually shift up and down in response to changes in afterload. And I'm going to talk a little bit more about that in the next couple of slides. So this is a graphical representation of ventriculovascular coupling, and this physiology explains a lot of unexplained phenomenon, and I think that a lot of this was pioneered by cardiologists up at Columbia University, and Daniel Burkoff comes to mind in terms of, the description of poor arterial compliance, particularly in elderly patients, as a cause of heart failure, where in a patient with very poor arterial compliance, if you picture kind of like the 90-year-old lady with very stiff vessels, this red line shifts way up and to the left, and so the cardiac function may be quite normal. The patient may have normal diastolic properties, normal systolic properties, but because it's ejecting into such a highly elastic, high elastance, low compliance arterial bed, you can actually get a physiology that represents heart failure. But I'm not going to get too much into that in these lecture here. But it's the slope of the end systolic arterial elastance curve, and that's abbreviated EA here, that defines the arterial impedance into which the ventricle ejects. And you can make a similar physiologic argument for the right ventricle and the pulmonary artery as well. So let's talk a little bit about arterial impedance. The slope of the arterial elastance curve that we just saw at end systole may be thought of as a summative illustration of arterial impedance. The arterial impedance is kind of a more true or a more physiologic measure of afterload, because it takes into consideration not just the classical resistance aspect of the arterial bed, which essentially, if you only considered that, you'd be assuming that the arterial bed is just an array of non-distensible, pulsatile conduits. But impedance also takes into consideration the compliance of the artery in addition to classical resistance. Resistance, as I'm sure you probably all know for many years now, is modeled after Poiseuille's law, and this truly really only applies to non-distensible rigid tubes. But as we know, arteries are distensible, and therefore their stiffness, which is related to their elastance or compliance, are also important determinants of afterload. And this distensibility of an artery you can measure in the pulse pressure, and it's the so-called Windkessel effect, which is German for, I forget, but it means that the artery pulsates when you eject a stroke volume into it. So it's not just these non-distensible tubes. And this is sort of a surrogate of a surrogate of a surrogate, but I'm saying that red arterial elastance curve that I just showed you in the last slide is kind of a summative way of depicting arterial impedance, and then impedance itself is considered the geometrical summation of both classical resistance, which follows Poiseuille's law, and reactance, which takes into consideration this vascular distensibility. So if you think of this as sort of like a triangle as geometrical summation, if you have this portion of the triangle as reactance, and reactance, this is unimportant clinically, but you can see that reactance is inversely proportional to the compliance of the blood vessel. And then this portion of the triangle is resistance, and this is what follows Poiseuille's law, which is, the resistance is related very heavily on the radius, the cross-sectional radius of the vascular tree, and as you increase the radius, you have an exponential decrease in the resistance. And then what impedance is, it's this geometrical summation of these two properties. And as I mentioned, that as vascular compliance decreases, there's an increase in reactance. So an increase in reactance would tend to increase the impedance, which is more of an important determinant of impedance and therefore ventricular afterload. Studies have shown in vitro preparations of explanted arteries and whatnot is that resistance plays much more of a role. And I forget the exact ratios, but I think it might be on the order of 3:1 or so. But the reference will be in the written volume. But resistance is more of the important determinant of the overall impedance, but certainly the distensibility of the arteries matter as well. So this is the elastance and impedance as I just talked about. So a high arterial elastance, i.e. a low compliance, as a marker of high impedance, what this does to the Sagawa pressure-volume relationship is it serves to increase increase diastolic filling pressure in subsequent beats, which is somewhat similar to impaired systolic function as illustrated in previous slides. So comparing this curve to this curve, this stroke volume has decreased for the same filling pressure. What would tend to happen on other beats is you'd tend to compensate by increasing your volume, which would then shift you up here. You have a higher, you may compensate for that stroke volume, but you'd be doing it at a higher filling pressure. So this could be like the little old lady with the poorly compliant arteries, and how these patients can have essentially normal diastolic and systolic properties of their heart, but still run into problems with pulmonary edema and heart failure type physiology. Whereas low arterial elastance is kind of a marker of low arterial impedance. So that would be illustrated by this curve here, and this might be the patient you've just given nipride to, or the patient who's septic, where you've lowered their impedance either by lowering outflow resistance, or by actually raising the compliance of the arterial bed. Nevertheless, this patient is going to eject and hit their end-systolic pressure-volume relationship at a much lower volume and a much lower pressure, and that will tend to augment stroke volume, as illustrated here. So what about valvulopathies, as I talked about? Well, valvulopathies are kind of the same as impaired systolic function. And I'm going to talk a little bit about regurgitation of the mitral valve, or the atrio-ventricular valves. And pathophysiologically, as I mentioned, it's similar to systolic dysfunction, and the reason why is because when you have regurgitation of an atrio-ventricular valve, it represents an effective decrease in the ejection fraction, and it responds quite nicely to both afterload reduction. So that's how you treat mitral valve regurgitation. You lower the afterload, which is qualitatively similar to pure systolic dysfunction. And additionally, it actually regurgitation of the mitral valve actually responds quite nicely to increasing the inotropic state as well. And so it can be modeled quite similarly. So if this is AV valve regurgitation, say mitral valve regurgitation, well, it's sort of like lowering your end-systolic pressure-volume relationship down into the left, because you're ejecting some of your cardiac output back into the left atrium, so your forward stroke volume is quite reduced. And what happens if you afterload reduce these patients is you actually augment the stroke volume, and this is the physiology that you see when you have a patient with mitral valve, really bad mitral valve regurgitation, and you lower their arterial impedance. And interestingly, I don't think I have it cartooned here, but increasing the inotropic state in patients with bad MR has been shown to improve the fraction of regurgitation, presumably by decreasing the volume of the ventricle and therefore decreasing mitral valve area and promoting forward flow through the aortic valve. Well, what about aortic stenosis? This is sort of like the epitome of very high arterial impedance to flow. And that can sort of be modeled by, it's not exactly the same, because really this line, this red line, is truly a marker of the impedance of the arterial bed. And you could actually, in theory, have normal impedance in the arterial bed, but if you have a fixed stenotic lesion in the aortic valve, you haven't actually really changed the impedance of the vascular bed. But nevertheless, it's kind of illustrative here that if you were to shift this curve up and to the left with a tight fixed aortic stenosis, well, then you're going to fill at a much higher pressure, and you may have a lower stroke volume. And this is fixed, and it cannot be changed. What I've illustrated here is that with time, with chronic aortic stenosis, then you may actually get hypertrophy of the left ventricle, and you actually may then get a diastolic dysfunction. This slide's getting a little bit busy, but now you've shifted as a result of chronic thickening of the LV, you've shifted the end-diastolic pressure-volume relationship up and to the left here, so now you're filling at a higher pressure for a much lower stroke volume. And I think you can see that because this is a fixed lesion here, you're not going to be able to lower your end systolic volume at all to augment your stroke volume. That if you lower your end diastolic volume at all, especially if you're on a steep portion of this curve, once you hit more of a flat portion of this curve, if you preload reduce these patients, as all medicine house staff know managing these patients on the floor, that if you drop the preload in these aortic stenosis patients, they die, and they die very quickly, and they don't come back. So I'm just going to finish off this second portion of Chapter 2 cardiac function with a brief talk on pulmonary vascular resistance, and this may seem a little bit out of place, but I think it flows nicely from our discussion on arterial impedance and a little bit what we just talked about with aortic stenosis. I'm going to focus more on the pulmonary vascular bed here, but really what the physiology I'm going to talk about in terms of pulmonary vascular resistance also applies to systemic vascular resistance. And there's a lot of misconceptions about vascular resistance, especially because when you float a PA catheter, you get a pressure, you get a flow, and then you assume that there's a linear relationship between pressure and flow, and you derive this very artificial systemic vascular resistance, which is a number which sort of summates all of the very complicated physiological parameters that go into determining your systolic, or your impedance, I should say, and it can give you a misleading idea of what's going on in the vascular bed. So when I say pulmonary vascular resistance here, you can think of it somewhat similar to the systemic vascular resistance as well. And I talked a little bit about this in the first part of Chapter 2 in that opening slide where, you know, the blood vessels are distensible and they are not rigid pipes that don't change. So the pressure-flow relationship is not linear, and I'm going to illustrate that in a moment. So vascular beds typically have this critical opening pressure, so you actually have to apply a proximal pressure head to the vascular beds, sometimes much greater than 0, and then once you hit this threshold pressure, flow begins to occur. And this is certainly true in the pulmonary bed. And the pulmonary vascular bed has this tremendous potential for parallel recruitment. That is, as you increase the pressure head as right ventricular pressure and sort of pulmonary arterial pressure increases, you begin opening these channels in the pulmonary vascular bed. And this occurs normally when you start to exercise. A large portion of your pulmonary capillaries may be actually de-recruited, and then as you start to increase pressure in the pulmonary bed, you have this dramatic increase in flow. It's an exponential increase in flow, and that's because actually resistance is dynamically decreasing as you're recruiting pulmonary vascular beds, and you're actually also distending the pulmonary vessels as well, so this facilitates that physiology. So the net effect, as I'm trying to explain, is that it's really erroneous to assume that a vascular bed has a linear pressure-flow relationship and that you can derive a single resistance variable that adequately describes changes in vascular beds. And this is because really the effective resistance is changing with pressure. So let's talk about pulmonary vascular resistance. So we'll map the driving pressure on the x-axis here and blood flow on the y-axis here. And so this is what you get off your PA catheter. You get your mean driving pressure, which may be your mean pulmonary artery pressure, less the pulmonary capillary wedge pressure, and that's your driving pressure. And then you get your flow, which is the thermodilution cardiac output that you get off of it. And then you happily divide the two, and you are essentially therefore assuming a linear relationship between the two. And you say, well, in this patient for a given driving pressure here, say, has a greater flow, and therefore they have decreased vascular resistance. And that's in contradistinction to this patient who has, for this same pressure, this same driving pressure has lower flow than this patient, and certainly has lower flow than this patient. So this patient here certainly has increased vascular resistance, and that's just simply applying Ohm's law to this biological system. But as I told you, the pressure-flow relationship of the pulmonary vascular bed and vascular beds in general is curvilinear, not linear, so you can get false positives. So if this curve here demonstrates truly what's going on in the pulmonary vascular bed, that is, as you're increasing driving pressure, you have to increase pressure, and then you hit this critical opening pressure, and then you start to increase blood flow. But then as the distensible vessels, as they recruit in the pulmonary vascular bed and they distend their radius, then you actually have lowering resistance, and actually blood flow starts to increase exponentially. And so now compare these two patients. So you've just done a vasodilator challenge, or you've made a pressor change, or you've added inhale Flowland to this patient, and you say, well, the patient initially had this driving pressure and this flow, and then I did this hemodynamic challenge, and now they have this driving pressure and this flow. And so certainly you calculate the slope. Certainly the slope has changed and they've increased their vascular resistance. But in effect, they're still on this curvilinear relationships, which defines the true physiology of the vascular bed. And in fact, this patient has not changed the physiology of their pulmonary vascular bed at all. And you've actually just concluded that you've increased their vascular resistance, and whatever you've done may be bad. But actually nothing has changed at all. So the key thing is that some people argue that calculating a pulmonary vascular resistance is meaningless and useless. And in fact, there's articles written by very smart people, much smarter than me, who argue just that. And it's based on this physiology. And this is also why when you're doing vasodilator challenges in pulmonary hypertension patients, you have to take into consideration not just a change in the pulmonary artery pressure and your mean pulmonary artery pressure, but you have to make sure that blood flow does not decrease. Because as you'll see, false positives and false negatives occur when pressure and flow move in the same direction. So in this patient, what has happened? Well, driving pressure has decreased, but so has flow. So has the driving pressure decreased because flow has decreased, or because there's been truly a change in the physiology of the vascular bed? You do not know. So what about a false negative? So this patient, you've done a vasodilator challenge, or you've added some vasopressor, or you've made a hemodynamic challenge. And this patient has actually changed the physiology of their pulmonary vascular bed, right? So this patient here, for a given driving pressure, they will have a much greater flow. And this could potentially be a beneficial thing. And I've just said that backwards. This shift into the right, I'm sorry, for this driving pressure, for this patient, they have a much lower flow than this patient. So this would represent an increase, a true increase in your pulmonary vascular resistance. But what happens is, the pressure and flow has truly changed, but if you calculate here compared to here, the slope, if you're assuming a linear relationship, you're going to get the same slope, and you're going to say actually nothing has changed. And again, like I told you, in this patient the driving pressure has increased, but so too has the flow. And so when pressure and flow move in the same direction, you don't know if pressure is increasing because flow is increasing, or because there's really truly been a change in the physiology of their vascular bed. And this, and that's just comparing these 2 points here. And this can be really said for the systemic vascular bed as well. So I've mentioned this point a few times now. So this is the last, I promise you this is the last slide of part 2 of chapter 2. This is a little bit of a clinical application. So this is, I forget who did this work, but this is real work. I'm not just making it up. Although sometimes making up some of these slides would be helpful. It would make my brain hurt a lot less. So what happens to the pulmonary vascular bed when you increase alveolar pressure? That is, you apply PEEP, or you increase the transpulmonary pressure, which tends to increase pulmonary volume. Well, it tends to shift the curve rightwards, and this is, as I mentioned to you, would be like an effective increase in pulmonary vascular resistance for a given driving pressure. You have less of a flow here, and so this patient is on a PEEP of 10, and this patient is on a PEEP of 15, so this patient has a higher transpulmonary pressure, which, as we will discuss quite extensively in, oh boy, certainly in Chapter 5, the physiology of extubation failure. And and certainly is in chapters 3 and 4, that transpulmonary pressure and lung volume is a key determinant of pulmonary vascular resistant right ventricular afterload. And then if you're to throw hypoxemia on top of this, so what does hypoxemia do? Pulmonary vascular vasoconstriction, and apply the same levels of PEEP. So again, PEEP of 10, PEEP of 15, but now this patient is hypoxemic. Now you've shifted these curves way off to the right. So these are much larger increases in pulmonary vascular resistance. And so for a given high driving pressure in this patient, you're getting much less blood flow, say, compared to this patient, certainly compared to this patient we had on the left. So that's all I have to say about cardiac function curves. Well, actually, that's not all I have to say. I'm going to wrap everything up and pull it all together in the following section. But what I wanted to take away from this section, section 2 of chapter 2, is that the Frank-Starling cardiac function curve, which relates right atrial pressure to cardiac output, which is bulk flow, shifts up and to the left and down and to the right as a result of various changes in cardiac physiology. And I think that the details of that are better illustrated by the Sagawa pressure-volume relationship, which we went through in terms of the end-diastolic and end-systolic pressure-volume relationships and how they change with valvulopathies and intrinsic changes in cardiac physiology, but also as a result of changes in arterial impedance, that is the impedance of the vascular bed into which the ventricle is ejecting, and that was demonstrated by the arterial elastance curve and ventricular vascular coupling. And so now that you are a master of venous return physiology and cardiac function physiology, in the third part of this chapter, we're going to bring it all together and integrate cardiovascular physiology, and then use that as the stepping off point for an integration of cardiopulmonary interaction, cardiorespiratory physiology. So go grab some caffeine and prepare to be amazed.